Okay, good. So it's really great to be here. Great to be here with Anna Diaz-Rue, who you heard serves on the Philadelphia Board of Public Health. I'm interested, before we start, to get a sense, how many of you work for academic institutions? All right, so that's most of the folks here, not quite everybody. So I'm sort of organized my talk around those people who are professors or work in academic institutions. I'm assuming then that some of you engage in local public health policy and advocacy work, and some of you don't. And I thought I'd take the opportunity of the talk to encourage those of you who aren't to engage in this more. I'm someone who was a professor, as Anna said. Now I'm in the real world of public health practice. I see a real value of you bringing your expertise into policy change and advocacy. And it's something which may feel a little bit foreign to you if you haven't been involved in it before. And so I organized my talk around that as kind of suggestions for how to do that, or I'm going to call it as tips. And so for those of you who engage in this, I hope these are useful to you. If you feel like you can't, well, at least then maybe you'll be able to understand the process a little bit better. So get my clicker here. The first, a little bit of background about how I think, as Anna mentioned earlier. I'm a big believer that policy change is the way that we make big changes in public health. We do public health programs like these, anti-smoking media campaigns and home visiting programs. We distribute naloxone for opioid overdoses. That's good. Those save lives. But those cost a fair amount, and it's a recurring cost, and it's something which is not necessarily easy to scale. And so whenever possible, we do policy and environmental change, because this is where we can have a much bigger impact, bring it much more up to scale, and have a much more sustainable impact. So cigarette taxes not only don't cost anything, they actually generate money for the government and the health department. Mandatory seatbelt laws, very effective. Limits on high-dose opioid prescriptions. So this policy change is what I'm always looking for, because the potential for big improvements in health. The other sort of bias I have coming into this is that cities I see as laboratories for public health policy making. Everybody's heard the term that states are laboratories of democracy. I think cities are the places where we really have an opportunity to do public health that have maybe been overlooked a little bit. And the reasons are that you have a geographic population that isn't exactly the same, but it's pretty similar to a political entity. So here in Philadelphia, we got 1.5 million people who live pretty close to each other. They see themselves as Philadelphians, but they vote for the same mayor. So they have some sense of unity and a political leadership. Now, there is a greater Philadelphia area, so they're not exactly the same, but they're similar. And then with that political entity, you have policymakers. You have mayors, you have city councils, you have boards of health. And so you can do things which you might not be able to do in a loosely organized, say, rural area. And our public health power, compared to the people who oppose public health, which is often industries, is greater compared to where we are at the state level or at the federal level. Because the industries can afford to lobby easily in Washington, pretty easily at the state level, but they can't afford to have a lobbyist in every city in America. And in cities, we can have personal connections and relationships with policymakers and that can kind of overcome whatever lobbying that's there. So it's never easy to get policy change through, but the scales are tipped a little bit more in our favor at the city, local level than they are elsewhere. So that's the background for why I think policy change in cities is something we ought to be putting more attention on. And so here are the sort of the principles or the tips for public health policy making. Think big, follow the marketing, don't just point at problems, propose specific solutions, weigh the legal and political feasibility, and then rally the right constituency. I'm going to go through each of these one at a time to say what I'm talking about. So first, think big. You know, we spend an awful lot of time, I think, in our research and in public health practice focusing on small problems. And I think that from that effort we put in, we ought to be focusing more on big problems. Why waste your time on small problems? We think about small problems or small solutions that really don't have an effect on population health or can't necessarily be brought to scale. And we have this problem that decision makers are often innumerate. All right, we all know that policymakers are more likely to be persuaded by anecdote than by data. And that's a reality, but that's a big problem too, because an anecdote about some person who suffers some health problem, it could be the same anecdote if that health problem affects 5 people or 500,000 people. And policymakers can be equally swayed by that one anecdote. And so if they aren't going to be focusing on the big problems, then somebody else needs to bring that to them. So it's, I think, our obligation as public health people to bring to them and say, no, these are the big problems. We have to draw attention to them. And so we need to really kind of hold our own feet to the fire about problems that are big, which then raises the question, how do you decide what's a big problem? You have to have some sort of scheme, some sort of data where you rank what you consider to be the biggest public health problems. And there are different schemes that probably different people in the room here would come up with, and that all, I think, would be legitimate. But this is the scheme that I use. So this is data from the Global Burden of Disease Project. It's done by a group of epidemiologists at the University of Washington. I hope many of you here are familiar with it, where they make estimates of how many deaths in countries around the world, but included in the United States, we can attribute to different risk factors, in this case, behavioral and environmental risk factors. And many people are going to quibble with the specific methods and their estimates, but the overall ranking isn't likely going to change if you change your methods. And by this, you can see my screen here, the leading underlying cause of death are unhealthy diet, smoking, alcohol use, air pollution, which I think doesn't get enough attention among public health people, drug use, and by that I mean illicit drug use and low physical activity. And all those pretty big. So those are sort of the things which we ought to be focusing on. Then follow the marketing. You know, I had what I consider to be a great opportunity a year or two ago where a reporter was writing an article for the New York Times, called up a bunch of public health people around the country, and he said, you know, if you had one sentence that you want to say to people about public health to include in this article, what would it be? So I thought about it for about a day, and this was what I told him. And I said that the problem is there's money to be made selling products that over time kill people. So much of my work focusing on those big problems that I showed on the last slide ends up trying to change policies that is resisted by industry. And the reason that they're resisting is they're making money selling these products that kill people. So to me, this is the biggest barrier to public health today. And if you think of that list I just showed you on the last slide, you can see how it translates to the products that people are selling that kill people, right? So we had unhealthy food, unhealthy beverages, tobacco, alcohol. There's one here in the list that you may not think of, and that is cars. And cars are underlying air pollution and physical inactivity. This is the biggest cause of those. So when we really try to make strides in that, we're running into that opposition. So these are what are biggest barriers to public health. And these products are not just sold by those companies, they are marketed by those companies. And there are techniques of marketing that include advertising, that go way beyond advertising, that can give us some clue as to what the opposition is likely to be, but also a clue as to what kind of policies we may want to put in place to change consumption of these products, which is underlying so many of our health problems. So think of this list for a second, just as a measure of what kind of, how much effort there is into marketing different products in this country. This is just data on the leading advertisers in the United States. And so, okay, there's unhealthy food, there's unhealthy beverages and alcohol, there's cars, and there's drugs. All right, so clearly we are being marketed to all the time with these products that over time kill us. And that leads us a clue as to what we ought to be doing about it. So this slide is about advertising, but I want to go off on a tangent now. Some might call this a rant about marketing, because people, I think, don't recognize the other techniques of marketing that can be so insidious and so effective in getting us to consume these products that over time kill us. So advertising is one thing, but if you were to go to business school, you'll be taught this sort of basic heuristic, the different P's of marketing. Usually it's told as the 4: product, placement, price, and promotion. I've added packaging here. And I illustrate this with Coca-Cola, because Coca-Cola is first and foremost a marketing company, not a beverage company. That's what they say, that, not just me. And they use all these techniques to get us to consume more Coke, and it works. But let me just show you how these techniques are used to market tobacco products, which everybody recognizes is a big public health problem. So here's how they manipulate the product to get us to consume more. Among other things, they started in the 1960s, 1970s, cigarette makers started adding ammonia to the tobacco leaves, which doesn't change the nicotine literally in the tobacco, but it does change the amount of nicotine that you absorb when you smoke. So it makes the products more addictive. People more addicted, then they're more likely to continue to buy the product. So that's one of many alterations of the product itself to get people to consume it more on a regular basis. Then there's placement. So if you were to go into pretty much any chain pharmacy other than a CVS in America today, and you go to the checkout counter, you see this, right? This is familiar to everybody. This is referred by people in tobacco control as the power wall. And it's effectively a giant advertising for smoking. Huge amount of space there. That isn't just a coincidence. That's because the tobacco companies pay for that space. And it promotes impulse buys. It also happens in a health institution, right? It's a pharmacy, a place where you go to get medicines that make you get better. And so it sends a message of how bad could it be if these products are sold in a pharmacy. So it provides a sort of health halo for this very dangerous product. So that's placement. Then there's price. So we raised the price of tobacco with cigarette taxes in Philadelphia and other cities around the country and other states. But the tobacco companies still manipulate that price in order to get people to do impulse buys. So you see all this like $1 off or specials today. What this is about is if there's a smoker who is trying to quit and really struggling with that impulse to pick up another pack of cigarettes, they come in and they see that low price, oh, well, let me just get this one more pack today. And it strings them along so that it makes it more difficult for them to quit. So this is one of many price manipulations that they use as part of marketing. And then there's promotion. That's the other P. Promotion in most people's minds is advertising. But there's promotion in a lot of other ways as well, including this, product placement in movies. So the reason that Lauren Bacall is smoking a cigarette there lit by Humphrey Bogart isn't just because she's a smoker, although she was, but because the tobacco companies paid the studios to have that happen in the campaign. And so all of us wanted to be either Humphrey Bogart or Lauren Bacall, and so we're going to take up a cigarette. That still happens today. Okay, so you see people like Brad Pitt, and I'm sorry, I don't know who she is, but I'm sure she's a very famous actress, smoking that. So product placement is still one of many promotion techniques besides paid advertising still happens. So those are the sort of things that make us consume more and the sort of things that we might be able to take specific policy action to get people to consume less. And my third tip is don't just point at problems, propose specific solutions. So here's where I'm going to get a little bit harsh and critical about what we happen to do in public health these days. There's an awful lot of talk about social determinants of health. I hear about it all the time. And social determinants of health are real, and they are important. They impact health. On the other hand, they are not a solution. And if you look to and say to people who are talking about, let's do something on the social determinants of health, and say, okay, but what should we actually do? That's when the conversation gets a little bit muddied. And just to give you an example of that, I once went to the website of the Kaiser Family Foundation. I don't mean to knock them, it was just convenient that it happened on their website. And this is their description of what the social determinants of health are. And if you look at it, it's kind of like everything. It's health coverage, it's access to healthy options, the early childhood education, it's income, it's hunger, it's employment. Okay, great. Now what am I going to do? It doesn't tell me what I'm going to do. So I think we spent far too much time talking about problems and not coming up with solutions. City council members or members of Congress cannot take this and turn it into legislation. They need somebody to say, okay, here's what we ought to do about that. So, in contrast, for at least those behavioral and environmental determinants of health that I showed you on the earlier slide, I can lay out a bunch of very specific policy solutions. Now, those policy solutions may make people uncomfortable because every policy solution is imperfect and has a lot of flaws and it raises opposition. So it's tougher in ways to talk about solutions than to just complain about problems. But I think this is our obligation to do. So, for example, for smoking, we can tax cigarettes. We can have smoke-free air policies. We can do mandatory graphic pack warnings. For obesity, we can do sugary drink taxes. We can prohibit sugary drinks in schools. For unhealthy diet, we can require lower sodium levels in processed food. For alcohol, we can do tax increases. We can put caps on alcohol outlet density. That's something very concrete, and you can take that to a legislator and say, put this in legislative language, make this happen. Now, that's going to be easy, but that is proposing specific solutions, and I think we don't spend enough time coming up with a list like this when we deal with people who are ultimate policy decision makers. So I'm going to go with more of my tips in a minute, but I want to sort of tell some stories as I go along here about specific policy change work that has happened, some successful, some not so successful, to kind of illustrate some of these principles, and also just because the story is a little bit fun. So story number one. This is going back almost, 17 years now in New York City. 2002, a new mayor came in New York City, Michael Bloomberg, and he hired his first health commissioner, which was Tom Frieden, and he was interested in addressing tobacco as a health risk. Tom Frieden came in and said, I'm going to work on tobacco seriously. And with a little work, Tom Frieden determined that the single best thing that they could do was to have smoke-free policies that made restaurants and bars smoke-free. That's now accepted around the country, but it was a very radical idea at the time. California had smoke-free restaurants and bars, but in the rest of the country, people went to bars to smoke almost as much as they did to drink. And the concept that you would not be allowed there was hard for people to wrap their minds around. And so Tom Frieden decided he needed to make that policy change. And the first thing he had to do was to persuade Mayor Bloomberg that he ought to use his political capital to make that happen. And I managed to get a hold of the slides he actually used to persuade Mike Bloomberg to go for this. So these are, Tom Frieden is not an unintelligent guy. He knows that Mike Bloomberg is successful based upon selling data to Wall Street. He's a data guy. All right, so he's going to persuade Mike Bloomberg with data. And so this is what he does. He first says, all right, secondhand smoke kills, and he puts a number on it. Here's how many people it kills in New York. So 1,000, compares it to things like breast cancer, and these other things which people get a lot of attention to. And then he estimates if we had a smoke-free policy, how many lives it would save. Now, for those of you who do estimates and are academics, if you were to dig into these methods, you would highly question how he came up with 11,000. All right? But that's okay. The point is it's a lot, okay? And a lot of these, for policymakers, you do need to make estimates that may not stand up to scrutiny for the New England Journal of Medicine, but they put you in the ballpark and make a point that's accurate, that these things have a big potential impact. So then he Tom Frieden ran into opposition in the rest of the Bloomberg administration, people who are interested in things like economic development, who said, oh my God, this is going to ruin the restaurant and bar industry in New York City. Nobody will ever go to a restaurant and bar again, and the industry is going to tank. So he said, all right, what data do we have on that? And he went to California, and at their website, he got data on sales in restaurants and bars before and after they went to smoke-free restaurants and before and after they went to smoke-free bars. And I think this graph is pretty clear. Okay, no impact whatsoever. Sales of anything are accelerating even as these bars and restaurants went smoke-free. And then the response to that was, you might be able to predict, that's California. That's a bunch of tree huggers out there. They're not New Yorkers. I mean, we New Yorkers, of course, we're the center of the universe. We're better than anybody. Nobody tells us what to do. We would be totally different. So Tom managed to get a hold of a survey that was done in New York State that just asked people, would you be more or less likely to go to a bar or restaurant if it were smoke-free? Most people said it would make no difference, but to the extent that it made a difference, they were more likely to say that they were more likely to go there than less likely. So then the criticism within the Bloomberg team was raised, something which at this point seems ridiculous, but it was taken very seriously at the time. This was that if New York City went smoke-free, tourists from Europe would never come to the city at all. They'd say, coming from Germany, forget it. If I can't smoke in a bar, I'm not going to New York City. Again, it seems ridiculous at the time, but it was taken very seriously. So what did he do? He decided to bring data on that. He called, about a dozen or so tour operators and gave them a list of factors that tourists considered when they're deciding what cities to visit in the United States. And this is what he came up with. Okay, things like culture, shopping. Smoking was down here at 3%. Okay, that's definitely not data that's going to go to the New England Journal of Medicine, but that was very persuasive. Okay, and so he managed to win. With Mike Bloomberg, when he's convinced to do something, he doesn't back off. And so he tangled in what was probably the most controversial issue that had come in front of the city council for years. So we had a giant cigarette there, and a huge thing. And the mayor himself went down to the city council and pleaded his case. And he won. It remained controversial right on up through the day that it was implemented. People were convinced that the industry would fall apart. New York City's entire economy would tank. This was, by the way, shortly after 9/11, and people told Tom Frieden he was crazy. He ought to be focusing on bioterrorism. He was smart enough to think big about what really kills people. And then this is ultimately what happened to smoking levels in New York City. So for the 3 years before he did that, the average smoking rate in New York City was pretty consistent at 21.5%. Now, there were other things done around the same time. They increased the taxes on cigarettes, but the smoke-free workplaces happened there in 2002. You saw that immediately they got about a 3% decline in smoking prevalence. And then with other programs and other changes, they reduced smoking rates by about a third over the next 10 years. So can't disentangle all those things, but overall a big impact on health. And they had a bigger impact than that. This is data from people who track smoke-free ordinances in municipalities around the country. And this is when New York City had their smoke-free law in 2002. You can see after that it really took off, and smoke-free ordinances happened in municipalities all over the country. And then later from there it moved up to states. So this is yet another reason why policy change at cities is important, is because when one city does something, the idea quickly spreads to other cities, and that cumulative effect of cities can then bubble up to policy change at larger levels. Okay, so back to my tips. The next tip is to weigh the legal and political flexibility. I showed you earlier this list of policies that could be put in place to promote health. These are, some of these are actually in place and some of them are not in place now, but it wouldn't be hard for a bunch of smart people like you to generate a long list of things that could be done. And the question is, which of these should you set as your priority? And I'm here to argue now that you pretty early on have to apply the filter of legal and political feasibility. Some of policies are legally not possible. They're preempted by the state at the city level. Some of them may not be politically possible given the unique political alignment of a city. Now, to a certain extent that maybe changes according to whether the city is more liberal or more conservative, but other times it may just be the quirks of the city. There may be one industry has its headquarters in that city. You're going to be much less likely to push something through where their headquarters is there, and then they have a strong lobbying presence. But it's not hard to sort of test out in applying this filter to figure out, okay, of the dozen or so policies that I want to put in place, this one we got a shot at putting in and succeeding in, and the other ones, no way. And so there's more policies that could be done than we'll ever have time to do, so it makes sense to apply that filter early on. All right, so let me go off into another story now, and this has to do with sugary drinks. This is a policy issue that I've been involved in for quite a number of years. An example has to do with the Philadelphia beverage tax, that we ultimately put it through. And so the background of this was that there was initial interest in passing a tax on sugary drinks in New York City, which ended up as a proposal in New York State because the city was preempted from passing its own tax. And it failed in New York State, but it generated enough publicity that the mayor of Philadelphia at the time, Michael Nutter, tried to pass a beverage tax here in Philadelphia. He tried it twice and failed. Got a little closer the second time than the first time, but failed both times. Then the current mayor, my boss, Jim Kenney, came in office in 2016, and during the campaign he had promised that he was going to expand pre-K in the city. And he came in and he needed funding to do it. He did not promise during the campaign how he was going to pay for it, but when he came in, he looked at all the different options and decided that a beverage tax was the best potential funding source. So he said, okay, let's see if we can get this to pass in Philadelphia. Now, back on this, so when it was suggested in New York City, immediately the industry came back and was lobbying hard and doing a bunch of public relations against it. This is what trucks looked like in New York City at that time. And the beverage tax also was proposed as one of the funding mechanisms for the Affordable Care Act at the federal level back in 2009 when that was being debated. And you notice that sort of generated a little bit of response from the industry. Okay? Huge spike in donations. There was a similar spike in donations that happened in New York State when this was considered. So the industry is quick to respond to this, and this response was successful. So at the federal level, that talk about a beverage tax to pay for the Affordable Care Act lasted about 3 months, and then no more talk about that. But so now we're here at Philadelphia, and we were engaged in this, although we were not leading the effort. And there was a group of researchers at Harvard that had developed a microsimulation model that estimated the health benefits of a beverage tax. And so they inputted data from Philadelphia for the tax that ultimately was considered 1.5 cents per ounce of how many deaths it would prevent. There were 349. How many costs it would prevent? $76 million. And a number of other factors. So it looked pretty good, and it was good to make a case. Now, I wouldn't say that the policymakers who voted for it actually believed those numbers, but at least some people that were paying attention did believe those numbers. The tax was ultimately structured as a volume-based excise tax, 1.5 cents per ounce. Any policy change gets altered in the process. The city council changed it to where they added diet beverages, artificially sweetened beverages in the process. And the bill ultimately came out. I'm sorry, I'm jumping ahead here. This was the tax that was proposed, and there was a big political brawl about it. The people who were proponents framed it in a way that was different from the way the opponents. The proponents framed it as Philadelphia was held back by a failing school system, deep poverty, and struggling neighborhoods. We're going to solve this by expanding pre-K. We're going to create 25 what they're called community schools. That is to say, put a bunch of social services in schools to help low-income families. And we're going to rebuild our parks and recreation centers so people have good places to play and revitalize our neighborhoods. And that the tax is really just a way to pay for all that. And the health benefits of the tax are secondary. We're not really going to talk much about that. So that's the way this was framed by the proponents. This managed to bring in a major constituency to support the tax, which was child advocates, parents of kids who might want to take benefit of pre-K, and teachers. Okay, and so they were there at every turn lobbying for the tax, which is a constituency that wasn't there in previous iterations of people trying to pass the tax. We have one teacher here who happens to hold her sign upside down. Don't hold that against her, okay? So we'll do better in the future. But this constituency was ended up being very effective. Now, the opponents was, of course, the industry, and they had their own framing about this. They immediately called it a grocery tax to imply that we were taxing food and something that was truly a necessity. They say it was going to hurt poor and minority people who have higher consumption of sugary drinks. It was going to hurt small businesses. We're going to lose jobs. And they argue the city should tighten its belt rather than try to raise more taxes. And they put out flyers like this, trying to make it look like we're taxing everything you get at a grocery store. To me, that's just a sign of how many bad things that they're marketing to us. They had lots of rallies. These are Teamsters who drive the trucks that deliver sweetened beverages and other beverages across the city. They're very well organized, lots of rallies, and they made this claim. The Teamsters had to lose 2,000 jobs if this tax is passed. And we had dug a little bit. Where did they get the 2,000 number from? That's the total number of jobs of people driving trucks that deliver beverages in the city of Philadelphia. So this would imply that the entire beverage industry would just go totally dead because of this tax, which is a little bit hard to buy. And they used all the tools they had available to them, which included these trucks. I show this picture because I think it sort of tells the whole story. Here we have Philadelphia City Hall, beautiful place for those of you who haven't seen it. Temple to democracy, the People's House right there in the corner of Broad and Market Street. You can walk right through it. It's really a sign of what we are as a nation, democracy, under siege by the Coca-Cola Company. All right, there's an army of the Coca-Cola Company trying to take over our democracy. That's the way I look at it. They did laps of City Hall there that I could see from my office. They're honking their horns, really trying to disrupt the entire functioning of the city government. So it was tough, but you know what? We won, all right? So here's the mayor on the day that we got this thumbs up from the city council. It wasn't easy. And what happened? So here's revenue from the beverage tax, bringing in about $77 million per year, which is really going to pre-K, getting I forget how many slots it's added by now, and those are really being benefited. Low-income kids are benefiting from those slots. And then here's what's happened to sugary drink sales in the city. So we had sales in Philadelphia just dropped off a cliff. They dropped by about 50% almost overnight with the increase in taxes. There was a claim during the debate that this wouldn't have any impact on consumption because everybody would just get in their car and drive to the suburbs to buy their soda and then drive back, which we thought was ridiculous. But actually, some people did cross the border to shop, and about a quarter of the decline in sales was compensated for by sales across the border. So net, there was a decline in sales about 40%. which is sort of similar to some of the estimates we have from our consumption estimates, from our consumption survey. So a big decline in sugary drink sales. Okay. Next step, rally the right constituency. To be successful, you need to have some kind of constituency. Constituency can be a mayor, elected officials, advocacy organizations, community groups, or fraternities and sororities. What's that about? Well, so here's another story. We, in Philadelphia, when I came in, recognized that we have more tobacco retailers per capita than any other major city in America, really by far. So we're at 2.2 retailers per 100,000 residents. New York City is about 1.5. And those retailers cluster in low-income neighborhoods. Each dot there on the left is a retailer. It's about 3,400 of them in the city. And the heat map shows that in North Philly, South Philly, West Philly, these are the poor neighborhoods in the city. And the difference is not small. So North Philly, the poorest area of the city, 3.75 per thousand population, whereas in the far northeast, a solidly middle-class section, we're at 0.75, so a five-fold difference. And I'm going to move fast here, but the data show that when we looked at it more closely. And those retailers are not just a place to buy tobacco, they're also a place for marketing. I talked about marketing a bit ago at marketing in pharmacies. But that point-of-sale marketing is the major way that tobacco companies spend their marketing dollars these days. And we know that point-of-sale marketing works. It prompts youth to start, it induces cravings, and addresses impulse purchases by adult smokers, makes your quit attempt less successful. So each one of those places in a low-income neighborhood is a place which really encourages smoking. And that's a problem for low-income neighborhoods. And that's probably why smoking rates are higher in low-income neighborhoods than they are in the rest of the city. The smoking prevalence is on the left here, and the percent of people living in poverty is here on the right. So this was the problem. We decided we want to try to address this. Fortunately, in Philadelphia, the Board of Health had the authority to regulate the number of licenses to sell tobacco on its own authority. Okay? And the Board of Health is a group of public health people, and they're not elected officials. And so the Board of Health came up with these regulations that put a cap on the number of tobacco retailers, 1 per 1,000 daytime population. Also put a tobacco-free zone around schools so the kids are not going across the street to pick up a pack of cigarettes during their recess. The way that we got there was not to take anybody's license away, but say everybody who's currently got a license is grandfathered in. But just as the stores close or as they're sold, we're not going to issue new, I guess they're permits, not licenses, to people in these other stores. And so over time, through attrition, we're going to get down to levels that are more like other cities and more appropriate. So that regulation went through, and immediately started to work. And I knew this because somebody tweeted this at us, that 7-Eleven was putting signs on the door that says, sorry, we can't sell cigarettes because of this stupid Board of Health regulation. Not our fault, blame them, which we were real happy to see. But that kind of complaint from 7-Eleven came up to the city council. And the city council considered a proposal to pass an ordinance that would essentially gut the regulations. What their ordinance would have done was it allowed stores, when they went out of business or sold, to transfer their permit to the new one. And if you could transfer to a new store, then we would never get a decline in the number of permits over time. We'd never see attrition. It would just freeze where we are forever. It also would have allowed companies to transfer permit from one location to another. So we could perpetuate the inequities of the higher number of retailers in low-income neighborhoods. So we were not happy with this, and we were concerned, and we were concerned that the 7-Eleven lobby was more powerful than us. And so we looked at things about the equity of this and tried to figure out how to show this. So we showed an example of a child in middle school walking to school in North Philadelphia would pass 16 different tobacco retailers on his way to school, compared to one in Chestnut Hill that would pass one. Okay? Low-income neighborhood, high-income neighborhood. That's not right. This is about parity and equity. And we showed the data that I just showed you, and we showed these slides to African-American fraternities and sororities who care about the health of folks in North Philadelphia. I was not aware of these organizations before. I'm embarrassed that I was not aware, because these are not just what people do in college. These are lifelong commitments. These are incredibly organized, powerful and effective organizations that care a lot, do a lot of community service. And when we showed them this data, they were outraged, and they said, we need to do something about this. And they advocated, and it became the army, or the constituency, to prevent repeal. Who's speaking there at the city council hearing is Carlene Weish, who's one of the sorority members. And she was speaking, and then we had advocates in the audience. I love this picture here because the most important advocate here is not the woman who's holding the sign, but if you look just to your left of her, there's an older woman just sitting there quietly. She sat there quietly during the entire hearing. But what I was told afterwards is that she and her other sorority sisters were texting the city council members who were their sorority sisters during the entire hearing saying, don't you dare vote for this bill. And it worked. We won. The bill got nowhere. And what happened? So this is the number of tobacco retailers per capita over time. And so from 2016 to 2019, we are now down 20%, or 650 fewer tobacco sellers in the city, with a greater decline in low-income neighborhoods than high-income neighborhoods. And here's where we are with smoking prevalence. We have a couple of different surveys, each of which has its flaws, but our smoking prevalence is going down and it appears to be accelerating. Can't say for sure that the tobacco retail regulations is playing a role in that, but it's certainly not a bad thing. So I'm running short on time. Well, I'm going to try to go quickly through this. We don't win every battle. Okay, we lose some. Quickly, here's one. We tried to regulate pharmaceutical sales representatives who are, to me, in large part responsible for the opioid crisis. The way that they do what they do is they give doctors free meals in return for a sales pitch. And there's good evidence here that the more free meals a doctor gets, the more likely he is to write opioid prescriptions. It really works. You wouldn't think a guy who makes more than $200,000 a year salary can be bought with a $10 sandwich, but they can. That's what the data says. And so we try to pass a rule that says you can't give free meals to doctors, and we were clobbered by the pharmaceutical industry. Okay, we didn't have an army of constituents that would rally on our side, and we lost that one. Here's another one. The on-ramp to smoking in Philadelphia are these cheap flavored cigarillos, flavors like watermelon and fruit punch and pina colada that they sell for $1. And so we had the authority, we didn't have the authority to prohibit these products, but we did have the authority to prohibit the flavorings. And we got the city council to pass the flavorings prohibition, and then immediately the cigar industry went to Harrisburg and passed legislation to preempt the city of Philadelphia from doing that or anything future on tobacco. So we got beat on that one. So it doesn't always win. So, but that's our overall set of tips and stories. So just to summarize again, think big, follow the marketing, don't just point at problems, propose specific solutions, weigh the legal and political feasibility, and rally the right constituency. And so hopefully more of you will engage in this sort of work in the future. And so I have to ask, who here will take on these industries? Because we need someone to take them on. All right, I'll stop there and be happy to have any questions answered. Thanks.